I'm Michael Dickinson. I'm a haematologist at Peter MacCallum Cancer Centre and Royal Melbourne Hospital, and I'm also the disease group lead for aggressive lymphoma. Today I'm just going to give a brief overview about the management of relapsed lymphoma, and I'll cover the most common lymphoma subtypes in brief terms so that I can communicate the general principles. As a haematologist, my approach with relapsed lymphoma is to try to achieve a good outcome, which in many cases means cure or a very long remission for some lymphoma subtypes. And so I still maintain a great sense of optimism for patients whose lymphoma has relapsed. I think about each patient individually. While we do have a framework for how we manage relapsed lymphoma, the patient's individual story is always very informative about our treatment choices. Because by definition, in some way, the lymphoma has proven itself to be a little bit refractory or a little bit resistant to the prior therapies given, we want to use a therapy that has a different way of killing the lymphoma to try to get on top of things as best we can. And so a detailed knowledge of a patient's prior therapy is very important for choosing the right treatment for relapsed disease. So what tools do we have? Well, for all lymphoma subtypes, we can reach for tools that are tried and tested, and we often have access to newer tools as well, and to clinical trials. And so broadly, I think about radiotherapy, conventional chemotherapy combinations, autologous stem cell transplantation, biological agents, and clinical trials. And for some patients, I think about allogeneic stem cell transplantation. What's autologous stem cell transplantation? Well, we can talk about this in great detail, and I'll only give you a brief overview now. But essentially, autologous stem cell transplantation is a way of giving chemotherapy at higher doses than we'd usually be able to give. The main point of autologous stem cell transplantation is chemotherapy intensification. And so, by its nature, autologous stem cell transplantation is not deliverable to some older patients or patients with medical comorbidities because of the intensity of the treatment. The basic principle is that bone marrow toxicity is a key limiting toxicity with respect to the dose of chemotherapy, and that as we increase the doses of chemotherapy, blood counts become lower and stay lower for longer, and that leads to infection and complications from low blood counts. So that's usually the thing that stops us from increasing chemotherapy doses. Autologous stem cell transplantation enables us to get around that. Essentially what happens is, for certain types of lymphoma, we choose to use this treatment because we've got some clinical trial data that suggests that by intensifying the chemotherapy doses, we can have either a longer remission, in the case of follicular lymphoma in particular, or cure in the case of diffuse large Bcell lymphoma in particular, and Hodgkin lymphoma as well. And so essentially, if a patient has a relapse of particular subtypes of lymphoma, we begin by giving standard chemotherapy, which is a different recipe, a different combination from the chemotherapy that was given when the lymphoma was first treated. And we do this to get control of the lymphoma and induce a remission. We collect stem cells using a peripheral blood collection procedure called apheresis. And what this means is essentially having a line, either a central line or a line into a vein, which takes blood out of the body and into a centrifuge machine, and we use that to remove peripheral blood stem cells. These stem cells are capable of repopulating the bone marrow and producing all blood cell types. And we can capture those stem cells by using a hormone called G-CSF, which is given as injections under the skin. We've learned from experience that the best time to do that is immediately after a chemotherapy regimen, and so it's our practice to try to capture those stem cells after salvage chemotherapy when the blood counts are recovering in the usual cycle, in the usual way that they do. But in some centres, autologous stem cells are collected after chemotherapy is finished and stimulated with G-CSF, but not connected in timing to the prior chemotherapy treatment. The stem cells are cryopreserved in a liquid nitrogen tank and kept on premises, and can be kept for years and years and can be used years and years later and still be effective at repopulating the bone marrow. But in this situation, it's part of a short-term plan. So we have the standard chemotherapy, we mobilise the stem cells and store them, and usually then we move to autologous stem cell transplantation. At this point here, it's typical to perform a PET scan to make sure the lymphoma is responding well to treatment and to decide at that moment whether autologous stem cell transplant is appropriate. We don't move to autologous stem cell transplantation if the lymphoma is getting worse, and we do move to autologous stem cell transplantation if there's been at least a partial response, and the case for some lymphomas we try to achieve a complete response before moving to autologous stem cell transplantation. This part of the procedure, autologous stem cell transplantation, is performed in the hospital ward, and what we do is we give high-dose chemotherapy called a conditioning regimen. The most commonly used conditioning regimen is called BEAM, B-E-A-M, each letter for one of the individual drugs. We use a different regimen called CBV here, but that is also commonly used in sites around the world. The chemotherapy is given for 5 or 6 days, and then after that the stem cells are reinfused, and that day of reinfusion is called day 0. And the idea is that the chemotherapies hit the lymphoma really hard, and as a bit of a side effect, it's hit the bone marrow cells really hard. Once it's washed out of the system, the stem cells are safe to go back in and repopulate the bone marrow. What then happens is blood counts drop, and typically patients require transfusions and antibiotics to treat infection, and then the stem cells repopulate, re-sow the seeds, as it were, for blood counts, and these blood counts grow usually over about 11 days from the time of the stem cell reinfusion. And so most patients are out of hospital within about 2 weeks of the stem cell reinfusion, and the whole package is about 3 weeks typically in hospital. There are some hospitals in Australia where this is done as an outpatient procedure, and patients are only admitted if they develop a fever, although that's less common. For some lymphomas, we follow up the transplant with a maintenance therapy, although this is less common in lymphoma. And sometimes we use radiation after or prior to the transplant to try to get a second anti-cancer modality in to control the relapsed lymphoma. Autologous stem cell transplantation is broadly applicable to most people with relapsed lymphoma, although as people go older than the age of 70, it becomes less and less feasible to deliver due to many patients as they get older being less able to tolerate this high-dose chemotherapy. Now, we don't use autologous transplantation all the time, and that first step of getting control of the lymphoma with a different kind of standard dose chemotherapy is often really important. And it's possible to stop there or continue with the standard doses of chemotherapy to achieve a durable remission in some lymphoma subtypes. And so autologous stem cell transplantation has to be applied judiciously and only in specific situations. One such situation is relapsed Hodgkin lymphoma. As you may know, Hodgkin lymphoma is often a disease of younger patients, although it does occur later in life in some cases. And in this situation, what we know is that radiotherapy is especially active in Hodgkin lymphoma. Now, we'll talk about it in a different video, but in the frontline treatment of Hodgkin lymphoma, chemotherapy is the mainstay, but for early stage disease, it's quite common to use radiation. If a patient has relapse within the radiation field, we don't reuse radiation within that particular location. If a patient relapses outside of the radiation field and the disease is still encompassable within a radiation field, then radiation is usually an important part of our approach to treating relapsed lymphoma. But the most important part continues to be, in most cases, giving some kind of whole body treatment that can attack the lymphoma in a different way from how it was treated the first time around. And again, we use salvage chemotherapy followed by autologous stem cell transplantation in most patients who are young enough to tolerate that treatment. And we use radiotherapy around the time of the transplant to manage any areas that weren't previously irradiated. If a patient has really widespread disease, such as stage 3 or stage 4 disease, it may not be feasible to use radiation as part of the overall treatment package. Now, there has been clinical trials of using brentuximab vedotin as maintenance therapy after autologous stem cell transplantation, and that is not currently funded in the Australian context, so we don't have access to that maintenance therapy. Now, if a patient is not able to have autologous stem cell transplantation or has relapsed after autologous stem cell transplantation, we have access to these two relatively new biological agents. Brentuximab vedotin is an anti-CD30 antibody drug conjugate. CD30 is a protein marker on the surface of Hodgkin lymphoma Reed-Sternberg cells and on the surface of cells of other types of lymphoma, but not too many. This is given once every 3 weeks. The antibody is attached to a toxin, and the toxin targets the lymphoma. And so you think of it as being like a targeted payload where this very, very toxic drug can be targeted just to the lymphoma site, but not released to most of the rest of the body. So it seems that brentuximab vedotin works in a way that's similar to chemo, but because it's so targeted, it has fewer side effects overall and can overcome chemotherapy resistance in many patients. This treatment is as I've mentioned, given every 3 weeks, and its key side effects are neurotoxicity, so change in sensation in the fingertips and toes, sometimes motor changes to the nerves, and also occasionally low blood counts. And the toxicity depends very much upon whether a patient has had autologous stem cell transplantation before and how long ago, but also it responds well to dose reductions. And so it's incredibly important if you're receiving brentuximab vedotin to communicate with your haematologist if you are developing side effects, because it is possible to adjust the dose of this drug and still have a really good outcome and prevent those side effects getting worse. The other drug that's available is pembrolizumab. And pembrolizumab is also called Keytruda, and it's become quite well known because it's used in other cancers in addition to Hodgkin lymphoma. And pembrolizumab is also given once every 3 weeks. This is a PD-1 inhibitor, and it works by changing the way the immune system sees lymphoma. Typically, it seems that the lymphoma prevents the immune system from attacking it due to the way the lymphoma works, and this is particularly true for Hodgkin lymphoma. We can interfere with that relationship between the lymphoma and the immune system using this antibody treatment, which essentially works to ramp up the immune system to destroy the lymphoma. And there's been impressive responses, and also, I should say, it's generally a well-tolerated treatment. The key side effects of pembrolizumab relate to switching on the immune system, and so we watch out for things like colitis, autoimmune endocrinopathies, so things like thyroid problems or diabetes type problems. Any kind of autoimmune disease of any organ can occur, and it can be quite idiosyncratic with pembrolizumab. For most patients, it's just a very well tolerated treatment, but occasionally, and not always early in treatment, sometimes late in treatment, these unusual but quite specific side effects related to the immune system can pop up, and they can be managed again so long as you communicate very well with your haematologist. It can be possible to continue treatment with that drug. And again, quite effective in inducing sustained remissions with respect to Hodgkin lymphoma. Diffuse large B-cell lymphoma is one of our more common non-Hodgkin lymphomas, and just like Hodgkin lymphoma, the principles are pretty similar. We begin by using a non-cross-reactive chemotherapy regimen to induce a remission, and then for most patients, autologous stem cell transplantation is our key pathway to cure. Now, what's important here is the response to salvage chemotherapy before autologous stem cell transplantation. As much as possible, we like to see that the lymphoma is shrinking and ideally completely gone before the autologous stem cell transplantation. And there are some patients for whom the salvage chemotherapy doesn't have the desired effect. In that situation, we might not proceed to autologous stem cell transplantation. Radiotherapy is less effective in diffuse large B-cell lymphoma than Hodgkin lymphoma, but we do try to use it in patients with localized disease or who have bulky disease around the time of relapse of their lymphoma. And that will be highly dependent on the treatment department where you're having your treatment, to what extent radiotherapy is a part of the overall package. But autologous stem cell transplantation can cure roughly a half of patients who've relapsed after frontline R-CHOP chemotherapy. For patients who relapse after autologous stem cell transplantation, the international standard of care seems to be chimeric antigen receptor T-cells, which are the subject of a different video. This is an immunotherapy where a patient has a custom-made autologous chimeric antigen receptor T-cells to treat the lymphoma. It's a very expensive treatment which is currently available in the United States and Europe and is approved for use in Australia but yet to be funded for this indication as of June 2018. It's under consideration by the regulatory authorities. Here we take cells from the immune system called T lymphocytes and train them to attack the lymphoma using a virus and grow them in the lab and then deliver them back to the patient as a one-off treatment. And we see that this particular treatment appears to be able to cure patients who have relapsed or refractory disease after 2 prior therapies, or who have relapsed after autologous stem cell transplantation. It's not a miracle cure, and it's a significant minority of patients who are cured with this treatment. We are able to offer this treatment by sending patients over the seas with government support at the moment through a program called the MTOP program. And of course, we hope that the regulatory authorities and companies will be able to reach an agreement whereby this can be supported in Australia. We are currently offering this treatment in limited clinical trials at Peter MacCallum Cancer Centre. This brings me now to clinical trials. Of the lymphomas that we have, because diffuse large B-cell lymphoma is relatively common, in fact there are quite a number of clinical trials designed to assist patients who have relapsed after autologous stem cell transplantation or who don't proceed to autologous stem cell transplantation due to their age or fitness or due to the extent of control of their lymphoma. And these trials are run at many big hospitals and small hospitals around the country and are designed usually to test new biological agents. The overall themes of the agents being treated is typically to harness the immune system or target the way cells communicate either within themselves to stay alive as cancer cells or between each other. And often there are combinations of these immune targeting agents and chemotherapy designed to try to build long remissions and in some cases cure. Now, I've mentioned before that clinical trials aren't of themselves necessarily the best thing, and your doctor will be able to talk to you about whether autologous stem cell transplantation is likely to be curative in your particular situation. There are factors we look at, like the duration of the first remission, that are very important, and some of the biological factors have turned out to be somewhat informative about the success rates of autologous stem cell transplantation. Many trials allow patients on even if they haven't had autologous stem cell transplantation, but it may be that the standard therapies are your best option. And so just because something's exciting, experimental and new doesn't mean that it's the best treatment option for you. And so it's very important that you discuss that with your haematologist and the doctor who's running a clinical trial. Follicular lymphoma is also a very common non-Hodgkin lymphoma, an indolent lymphoma for which there are lots of treatment choices. Of all the lymphoma subtypes, this is the one where the approach to relapse disease varies quite a lot from patient to patient and circumstance to circumstance. This is because follicular lymphoma often responds to chemotherapy time and time again, and although the duration of those responses is usually shorter than the prior remission, if the prior remission was 5 or 8 or 10 or 12 years, then one could expect the second response often to be quite long. The other thing to say is that follicular lymphoma can respond quite well to non-chemotherapy agents, and there are some that are registered for use in the Australian context as well. We do use autologous stem cell transplantation for particular situations, and we've learned that patients with follicular lymphoma who relapse within 2 years of first therapy might particularly benefit from high-dose chemotherapy, where some studies have suggested high-dose chemotherapy and autologous stem cell transplantation really can increase the duration of a remission. So autologous stem cell transplantation is less of a default option in this disease, but is a tool that can be used and can be useful in particular circumstances. Now, I haven't talked about allogeneic stem cell transplantation yet. Allogeneic stem cell transplantation has a similar process in that we do use stem cells, peripheral blood collected, typically stem cells, just like on autologous stem cell transplantation. The difference with allogeneic stem cell transplantation is that we use stem cells from someone other than the patient, and the goal of that treatment is different from autologous stem cell transplantation. Here, the goal isn't to facilitate high-dose chemotherapy, but for the stem cells themselves to do the anti-cancer work. And essentially what we're harnessing here is somebody else's immune system to see the cancer as foreign and reject it. And this particular treatment is commonly done around Australia, and there is a role for it, particularly in follicular lymphoma, in patients who are young enough to be able to tolerate the side effects of treatment. I'm not going to talk about the side effects of allogeneic stem cell transplantation in any detail here, except to say that they are quite different from autologous stem cell transplantation, and the patient population for whom allogeneic transplantation might be beneficial is smaller than autologous stem cell transplantation. Nevertheless, because follicular lymphoma, as an indolent lymphoma, does have a habit of relapsing over decades, for a patient who has many, many decades of normal life expectancy ahead of them, there may be a role for an immunotherapy like allogeneic transplantation to try to eradicate the lymphoma using something other than chemotherapy or biological agents that need to be continued indefinitely. There are trials currently active of chimeric antigen receptor T-cells in follicular lymphoma at a number of sites around Australia, but there are also lots of trials testing agents across the Bcell lymphoma subtypes, and so of all the lymphoma subtypes, follicular lymphoma probably has the most choices of novel clinical trials, immunotherapies, biological agents that are currently being tested in the Australian context. And in fact, there are probably more trials than there are patients in this particular disease. So there's lots of treatment options to be discussed. And at the moment, quite a lot of work being done on how to have a long-lasting remission. Mantle cell lymphoma is a special lymphoma. It's one of the more rare lymphomas, and it presents usually at an older age in life. For younger patients, the treatment in the frontline setting is much more intensive typically than diffuse large B-cell lymphoma or Hodgkin lymphoma. In this context, we use autologous stem cell transplantation as frontline consolidation therapy, which means that in most patients who have relapsed or refractory mantle cell lymphoma, they've already had autologous stem cell transplantation, which means that it's not a tool that we reach for very often in patients with relapsed disease. In this particular situation, there is a biological agent called ibrutinib, a BTK inhibitor, which is active at targeting mantle cell lymphoma. We do use allogeneic transplantation in younger patients, and there are emerging immunotherapies and clinical trials for this particular disease. Also, just like all of the other diseases I've discussed, non-cross-reactive chemotherapy can provide a very useful and durable remission in this particular type of lymphoma. So quite a lot of clinical trial activity, and particularly here in Parkville at Peter Mac and Royal Melbourne, there's been some very interesting work done on the role of drugs like venetoclax and ibrutinib, both separately and in combination for this particular lymphoma. And so it's important that you discuss your trial options with your haematologist if there is a relapse of this disease. Chronic lymphocytic leukemia and small lymphocytic lymphoma, for all intents and purposes, are the one disease. I'm not going to discuss those in detail in this video because they're being discussed elsewhere, but suffice it to say, allogeneic transplantation has a greater role in this disease than autologous stem cell transplantation. Chemotherapy intensification is less important, and biological agents are more easily found on the pharmaceutical benefits scheme, have durable remissions and are well tolerated, and there are also some very interesting clinical trials in this space. So less of a role for autologous transplantation for these two diseases. What about T-cell lymphoma? Well, T-cell lymphoma is pretty rare, and if you're a patient with T-cell lymphoma watching this video, I can imagine that you've had more difficulty finding information about your lymphoma subtype than patients with other types of lymphomas. And that's because T-cell lymphoma is just relatively uncommon. We see a fair bit of it here at Peter MacCallum Cancer Centre because we have a skin lymphoma clinic, and T-cell lymphomas often present in the skin. So we do have a population of patients that we see through this clinic. And we've run a number of clinical trials over years that have tried to improve the outcome for this disease. Here, just like mantle cell lymphoma, autologous stem cell transplantation is commonly used as consolidation for frontline therapy. And so it's a tool that we've already used at the time a patient relapses. Now, the thing about peripheral T-cell lymphoma is that there are some biological agents that appear to be a little better than conventional chemotherapy in this situation. And I reached for the PBS-approved pralatrexate drug in patients who've relapsed after conventional chemotherapy. And there is a drug called romidepsin, which we currently have available through a research program here at Peter Mac, and which is available unfortunately not supported by the pharmaceutical benefits scheme. This is an expensive drug, but does appear to be active for a significant minority of patients, in which it can deliver a durable remission but requires continuous ongoing therapy. There are a number of clinical trials active in peripheral T-cell lymphoma at centres around Australia, and there is a T-cell lymphoma network of physicians who are communicating about these trials and trying to provide more opportunities for patients with this particular lymphoma subtype. So I've talked already in each disease group about trials, and I guess that the main thing I wanted to emphasise at this moment is that to re-emphasise the point that trials, they're good. One of my professional joys is trying to develop new therapies for patients with lymphoma and develop less toxic therapies and more effective therapies. But just because there's a trial doesn't always mean the standard therapy isn't the best treatment option for you. The other thing to say is that there are places to find information about trials. Lymphoma Australia will be able to point you in the right direction. Our hospital has a website which points you to the registry links for all the different trials that we have. And there are iPhone apps that talk about which trials are open, including an app called ClinTrial Refer, which is really designed at a medical audience, but is available freely, and you can see what clinical trials are open. It can be quite a difficult app to navigate because of the very medicalised nature of the information that's in there, and so you really will need the support of an expert in interpreting the information that's there. But it's important that you look around for your treatment options if you have relapsed lymphoma, because sometimes the trials are comparing standard therapies with novel therapies. One of the research themes that has come out recently and which we're focusing on here is chimeric antigen receptor T-cells, and in diffuse large B-cell lymphoma we're running a trial that compares chimeric antigen receptor T-cells or CAR T-cells with autologous stem cell transplantation, and that's true as of June 2019. One thing about trials is things change very quickly and without warning, so something I say today might not be true next week, but to the best of my knowledge the trial will be open for quite some time. There are a number of really interesting biological agents available in lymphoma at the moment, and there's a very active research community in the space of lymphoma in Australia with very good clinical trial sites, and I include of course Peter Mac and Royal Melbourne as one that we're very proud of. We run a strong lymphoma trial service here, and it is possible to make inquiries through us going straight to our website. You can look up the lymphoma services, and the referral pathways should be fairly clear to navigate through our website. So in summary, usually in relapsed lymphoma there are several treatment options. We think about the patient's disease characteristics and the patient's personal characteristics, prior therapies, the role of intensive chemotherapy and radiotherapy, and then we turn to biological agents and clinical trials depending on the individual lymphoma subtype and the patient's personal history.